anything else, we have shift will occur when there's financial hardship. And I think it will happen pretty quickly as we see maybe the need for screening colonoscopy going down.
Dr. Nadeem Baig and Dr. Bob Gialanella, welcome to the Scope Forward show. Thank you so much for being here. And again, I'm excited to have this conversation with you.
Thank you, Praveen. Much appreciated.
Praveen, it's an honor and pleasure to be on this podcast with you today, and with of course, my partner in arms, Bob Gialanella. We're really thrilled and honored, to be part of this, great service you're providing to the GI community and beyond. I just wish I had something like this in my training days, where someone was actually collating, curating all the best and emerging practices in the business and practice management side of GI and medicine. It's just a wonderful resource for physicians like us in the community.
Thank you so much for saying so. I want to first start right from the beginning and ask you, how did Allied get started, way before the PE days?
Sure. We formed Allied Digestive. It was a sort of a brainchild of I and Nadeem's in 2014 or so. We were 5 competing groups in the same geographic area, and we had multiple meetings and explored other possibilities with large multi-specialty integrated groups, and decided that we really wanted to be single specialty. And in early 2015, we all took the leap of faith and merged 5 groups that had previously competed with each other. And we decided that we would be much better together than apart. And at that point, our cultures were very similar. Our quality also very similar, which was very important. And then we took on the task of integrating operations, tracking quality metrics, creating a central business office to handle all the operational needs of the practices. And that's how we basically did it. It wasn't easy in the beginning, loans, a few stumbling blocks in the first year or so, but we pulled it together, and we all kept rowing in the right direction. When we look back on it, people say to us, "We can't believe what you've done in such a short period of time." But it wasn't for people like Nadeem and our other board members and the overwhelming need for this type of consolidation, looking to the future and the present market in GI. We wouldn't have done it, but here we are, and very happy to be here and talk to you about our journey.
So Bob, what is the difference between this MSO and the MSO that is now forming together with your private equity partner? Because based on what you're saying, you pretty much did what different platforms have done in partnership with a private equity company. So you were doing it already. How does this change the game for you?
3 years ago, again, it was a board initiative to create an MSO. This was in anticipation of either a private equity partnership or maybe becoming multi-specialty. And you need an MSO to handle multiple specialties. So we were a bit ahead of the game. And that's what made us so attractive to our private equity partners, is that we already had an MSO in place, and it was licensed and it was operating. So it was very easy for them to partner with us because we didn't have to create a new company. The MSO is basically our previous CBO sort of on steroids. It just works more efficiently. We become much more attractive to very high level executives because now not only do they get paid well, they have equity in our company. And that really, to me, that's alignment and retention when you're all, basically partners in the same organization.
Mm-hmm.
Praveen, may I just add also that, partnering with our private equity company now, I think as Bob alluded to, it allows us to now invest more in the company. Mm-hmm. Traditionally, as you know, Praveen, very well, medical practices and physicians who are part of medical practices tend to want to take every dollar out, a profit, for themselves. As they feel it's their income they've hard earned, through seeing patients, doing procedures. So they want to take that home, and they invest some in the company, but, especially with these emerging changes that are currently going on in the healthcare climate place, a good company really invests in itself. And it's not just investing in new technologies or new modalities, but it's investing probably the best resource of all, human capital.
Yes.
And we learned this a couple of years ago that when we went out and hired a healthcare executive with expertise in hospital management, and also from the Kaiser Permanente in the value-based care world, in a sense, it was enormous value and benefit to the organization, and be able to grow and get to where we are now. But it costs money to pay for that high-level executive employee. And before we formed Allied, I don't think anyone else would have even thought or considered the possibility of hiring someone of that caliber and scale, and the cost that comes with that service.
Yeah, it's Nadeem's absolutely right. It's sort of, we all worked on sort of this flow through type of economics, right? As opposed to capital investment. In our particular case, the important thing was we were looking at a strategic financial partnership that allowed care center autonomy and clinical autonomy. You may not find that with a large multi-specialty group or a healthcare system. And we looked at all three models. And by far, this one allowed us the clinical autonomy and operational autonomy, and did not disrupt our care center culture at all. Mm-hmm. So our care centers operate just as they did prior to ADH. Their compensation agreements stay the same. Their clinical staff stays the same. All clinical decision-making is unchanged. That was very important, to find a partner that would invest in us, but allow us those freedoms. And we did. Mm-hmm. The process that we went through, I was always, and Nadeem felt the same way. We always talk to our board, like, we're going to have to spend capital to get the best. So we looked around, and Nadeem, through DHPA, our National Advocacy PAC, he has been in contact with 3,000 gastroenterologists, like-minded independent practitioners around the country. And that's how we found Nexus Healthcare Capital, Catton, our law firm, who had been involved with the largest GI platforms in the country. And they really knew how to do this. So we immediately, partnered with them as well. And that was sort of the process that started us. And they were just phenomenal. I mean, they educated our membership, especially our younger membership. There's always that, I call it generational divide when you go through something like this. The younger people see things a little bit differently than the older partners. So we had to close that gap. And really, we did it. Our investment bankers, I thank them again. They spent day and night educating our junior membership. And after it was all said and done, they realized that this direction was the best one for them as well as us.
So I wanted to touch upon that whole aspect of junior partners versus senior partners, because a lot of people struggle with it. How did you make the case to the junior partners who think that all that the senior partners want is an early retirement fund or an exit quickly from private equity? How did you make that case?
When Bob and I first formed Allied, I think I told Bob this, told my student board members as well, that I helped to drive and form this company, not so much for the senior partners, but really for the junior partners and the junior associates. It was to provide financial stability and quality of practice management and care for the long term, not just for the next 5 to 10 years. And we achieved in great measure over the last 5 years with Allied. That strategic goal, objective, did not change when we partnered with private equity. I felt the same way now as I did 6 years ago when we formed Allied, that this is just as much a means to provide financial stability and security and quality of practice management for the junior partners as it was back then. It's just meeting and arriving at a strategic goal, which was set out, we formed Allied, was to grow the company from day one, to keep lockstep and pace with the other major stakeholders, whether it's healthcare systems, payers, biotech, pharmaceuticals, pharmacies, etc. We just want to keep lockstep and pace with them, and this helps to ensure that. And that was a driving message we made to the junior partners, in forming this new partnership.
I think, it also, if you look at the economics of it, in a model like this, really, the longer you're in it, the better off you are. I think if our junior partners got, as you said before, Praveen, 2 or 3 bites at the apple, they would see the benefit in this type of corporation.
Mm-hmm.
So we were very, very mindful of taking care of them with equity in the MSO, with changing partnership tracks within their care centers. We decided it was important that the care centers sort of do away with their legacy buy-sell agreements, and we standardized all that. So no one care center looked more attractive than another to a new recruit.
How was valuation done in your transaction?
Valuation, as you know, is all based on EBITDA. You go through an extensive due diligence process, legal, economic. It took months. And then there was back and forth with Nexus Healthcare Capital to get us some extra. But it was a very laborious process, especially from the legal standpoint. I think Nadeem and I were on a couple calls with regulatory lawyers. I felt like I was on the witness stand, but we were happy to know that at the end of the day, our company was perfect in that sense. They couldn't, they really, we were always mindful of those type of things as we put Allied together, of, abiding by all, the Stark laws and local, laws as well. We're very fortunate in New Jersey to have excellent corporate practice of medicine laws too, which really defined our relationship with our private equity partners and gave us a lot of comfort in the fact that, there was a clear separation between the practice and the MSO. And we and our partners were very happy for that too, because there was no gray zone. So we all knew what our roles were. We all knew how our care centers would operate, and it gave a lot of comfort to us as well.
So I want to get into this valuation and EBITDA a little bit more. As we know, the way currently valuations are done, it's based on future physician productivity, and that future physician productivity is based on the number of procedures that are done. And for GI, a good part of those procedures pertain to colonoscopies and screening colonoscopies. And each of those are connected to other ancillaries, like, pathology is connected, anesthesia is connected, and so on. So if something disruptive happens to that primary revenue stream, then it is possible that everything else gets affected. So I'm curious to know what happens in that case to EBITDA assumptions, and what is like a plan B when, in your discussions with your PE partner.
Yeah. So I look at it as 2 different types of EBITDA, right? There's mergers and acquisition EBITDA, groups that you add, okay? And then, internal EBITDA. It's how the existing physicians in Allied increase their revenue stream. Now, when you talk about disruptive technologies that may drive down the necessity for screening colonoscopies, I think we have to look at it in terms of income diversity. If screening colonoscopies go down because of some disruptive technology, then we concentrate more on treating chronic illness, like liver disease, like inflammatory bowel disease, like irritable bowel syndrome. There's many diseases that don't have to do directly, they're not procedurally oriented. So we expand those service lines.
When Allied first formed, I was a bit of a data nerd, and my second life, I thought I should have become a mathematician or an accountant, because math was second nature to me. So early on, I through our EHR, I was able to dig into financial data of the organization, and I came across a pretty startling fact, which Praveen, you're very attunely highlighting, both in your books and in your other conversations with other thought leaders in this area. Our over 70% of our revenue in the organization was being derived through 4 CPT codes. There are 1 EGD code and 3 colonoscopy codes. I said to Bob and myself that we're way over leveraged, in this one line, in this few lines of service. So, we felt that we had to start diversifying, and it takes time to work that out. And part of it, of course, is the limitations are previous working cultures and environments, and just the mindset of physicians who are just attuned to practicing medicine in a certain way because that's the way they've seen it happen for 20, 30, 40 years. Once we're done with the COVID pandemic, we have to go back and focusing upon the original pandemic of the 21st century, which is obesity, and that's still an area that's not being adequately met by, physicians and practices and other healthcare providers across the country. As you see, Praveen, there's already a lot of good innovative solutions out there from Michigan, I think like Modify Health, and other new platforms out there. I think, we are, it's right time for us to get more engaged in.
How long do you think before, all this happens for GI as an industry? The shift from reliance on procedures, those 4 CPT codes, because it's true, it's true for almost every practice out there. Before that shift happens from that reliance on those codes to these newer diversified revenue streams.
Anything else? We have shift will occur when there's financial hardship, and I think it will happen pretty quickly as we see maybe the need for screening colonoscopy going down. But I also look at it another way. If you have a non-invasive test, we may be picking out more higher risk individuals, and they will be coming our way.
I think we have to be a bit, have a sense of, honesty, humorous about this. 10 years, every so often there has been threats to colonoscopy. 10, 15 years ago, we were dealing with the CT colonography program. In fact, one of our member practices, before they joined us, they invested heavily in a CAT scan machine, expecting that this is the future. Colonoscopy is going to go down. CT colonography is going to take over. Guess what happened? It didn't occur. Medicare never covered it. Prior payers never really covered it. And that practices literally went under, because of that bad investment. So, it's one thing, I think, to appreciate that, the future trends that we do expect colonoscopy decline. We also must recognize that colonoscopy for screening has been extremely effective, and is a high bar for other technologies to meet that threshold. We've seen a 50% reduction in colon cancer incidence and death in the past 20 years with the use of colonoscopy for screening. And there are going to be still a lot of patients, I think, that are going to still choose colonoscopy over other modalities, whether it's Cologuard or other types of stool-based DNA testing or liquid biopsy. So the most important thing we can recognize is there's still patient choice that will still play a factor. But nonetheless, we do expect it to go down. And as Bob said, one way is to be reactive, just see our decline revenue and then try to adjust. But that's not a job of good leadership. And good leadership that I think we have in our organization and our partners, with our private equity side, recognize that we do have to look ahead and look forward at finding new other areas to be involved with, that with the goal of, number one, providing good quality care for our patients. I think I've heard some other people, other thought leaders. We want to say it here again. You always want to put patients before profits.
Right.
And if you focus your goal and objective on that, you will succeed in healthcare and practice. And the one thing in Jersey we have a great advantage of is that we have payers that recognize and want to engage in alternative payment models, want to engage with, patient-centered medical homes, new ways of managing chronic disease that reduce the overall cost of care while improving that side through the triple aim scores. So, that's where I think we see an opportunity to start to work with our payers in a new role where they're partners, not their adversaries.
If you read any of the news articles that are escaping about the whole private equity space, there was one in Bloomberg. There's one. You pick some of the new magazines, and there are some articles talking about it. The issue happens when PE seems to dictate, the clinical aspects, of maybe pushing not physicians, but maybe APPs instead of physicians for certain procedures, or pushing certain procedures which are not needed. And especially, you would read this in the case of dermatology. Now, my question is, given that background does exist, how are you ensuring as a platform that you're keeping, the business interests and the clinical interests separate?
Yeah, as I said, we have separated it pretty well. All of our licensed practitioners are employees of Allied Digestive Health, the practice, and others are employed by the MSO. So there is a sort of a firewall there between the people that operate the company and the clinicians. I think in our situation, we figured that out. Now, you could say as the platforms get larger and they get multi-state, and you can lose that local control. And I think that's what happened to dermatology out in California. They lost that local control, and maybe you can make an argument for that. That also happened to emergency room doctors, where they had no idea where the MSO was and who the executives were, and it became such a foreign entity to them that they became just labor and treated like labor. So COVID happens, there are layoffs, which is really devastating to a physician. So I think, there's not, the majority of the states in this country don't have good, corporate practice and medicine laws. We're very fortunate in New York and New Jersey. So I can't, and I think also our second partner has to be chosen very carefully. And our partners at Assured have they also let us know that will be a very long conversation with all the clinical practitioners and the clinical side of Allied Digestive, as well as the MSO side. So I think the next partner we choose will be like-minded, probably another large GI platform that is structured just as we are. And I think that helps a lot. The problem is I think when private equity gets too big and these companies are bought out by people not in the medical space, whether it be insurance companies or other corporations, that's where you start to lose that control, because they just look at, sort of your P&L, and, we are a patient-centered practice, a compassionate patient-centered practice, and we're going to keep it that way.
It's our job as clinicians to make sure that, we're always focused upon the patients, and have to keep, that our private equity partners, appreciate the need of providing good quality care. One of the reasons why they said they really liked us over other potential GI groups that they were looking at was because we provide high quality care. They said you have the highest ADR rates we've seen. of any GI group. Says we really like that. So I think they also acutely recognize that, especially in this emerging value-based care world, which they embrace, and any good private equity platform that works with any medical practice should also embrace that quality is a key element of value-based care. If you don't provide good quality, you will not, be a valued partner, with the other key stakeholders, whether it's healthcare systems, and most importantly, patients, payers, and employers, because ultimately that's what they care about.
Mm-hmm. Thank you. So I want to comment back on one of your points, Bob, which was, and again, I'm saying it in my own words, that as of now, yes, it's restricted to private practice medicine, and perhaps in your case, very regional, very local. But as you go to the future, and that actually takes us to my final question, which is, where is all this consolidation going in your view, and what do you see happen over the next 5 years? But connecting the dots a little bit, it is going to take us in some ways in the direction of going beyond private practice too, right? Like, so there are limited partners who own private equity players. There are insurance companies that are also interested in the provider side. There are large health systems that are also connected to private equity and beyond, and they're investing in physician practices. So it is going beyond the hands of physicians. So how much control will physicians have? It's a multi-pronged question. So I'll leave it up to you to, how.
Yeah, that's a great question. I think there surely will be a lot of consolidation in the next 5 years. There's 9 GI platforms in our country. So I would like those platforms to get together and hopefully not sell out to a healthcare system and, grow this autonomous sort of model that we have that may be a little far reaching. But I agree with you. I think the next partner that we have, the first, second bite of the apple, more to say, is the most crucial move we will make as far as what our company looks like in 10 years from now. And I wouldn't be surprised if in 5 to 10 years from now, there are probably either one big GI platform across the country or 2. It may get to that. But I think that's where we have to have a real discussion with our private equity partners about, who our next partner is. It's extremely important. And, for the longevity of Allied Digestive Health and the happiness of its physicians. Right now we're young. I mean, GI is young in this space. We really don't know what's going to happen.
Yeah. Praveen, let me just add my 2 cents on this. First, when Bob and I, started this company along with others, several years ago, one thing we're focused upon is trying to maintain our autonomy and keep physicians in the driver's seat in managing the care of our patients. I was tired and remaining and staying a pawn in the healthcare chessboard. And clearly, as we consolidate with other stakeholders doing the same thing, we have no intention of, remaining or ever going back to being a pawn on that chessboard. I don't think we're a queen, but maybe we're a knight or a bishop or a rook, I'm hoping, in that board. But beyond the consolidation part, which is what everyone's been out gaming for. It's the challenge going to be for really the successful groups is to, what do you make of that consolidation? What do you do when you finally merge all these, hospitals or pharmacies, health systems? I think as Jim Weber said it really well in a conference, and Jim Weber being PD of GI Alliance, he's the president CEO there, says, you don't get big to get bigger, but you get big to get better. And that's where I think, we're going to focus on an Allied. I think running good, GI platforms that are consolidating, or would be all wise to do the same. And, those 4 trends I look at beyond consolidation One is, is adapting to payment reform, from, both the government and the private payers, who are definitely pushing us to fee for service, to value-based care, and also, giving us, using the new tools that the government just provided us with the stark anti-kickback reforms that CMS just enacted a couple months ago. Other big trend, you're very, very attuned to this, is the digitization, of healthcare. Healthcare is the last group of people to ever adapt to newly evolving trends in digital space. I mean, people can book appointments online for their airline, their car, lodging, but it's still hard to book an appointment online to see a doctor. But we're getting there, and it's not just that customer relations tools, through our EHRs or through telemedicine. It's finding better ways of connecting with the patient in their space at a way they feel comfortable with, and they feel they have still maintained their privacy. The third big trend to look at, as you alluded to, is adapting to innovation. Not just in new ways of testing and diagnostic modalities, but also new service lines, and being prepared for those disruptive technology of innovation. The last one I want to focus upon is going from a reactive posture to a proactive posture in care management. Medicine has really progressed, through the ages, from reactive healthcare, waiting for the patient to come see in the office till they're sick, waiting till they come to the hospital, the ER, to more proactive. And, this is in various fields of seen this across. And of course, now moving to even preventative care, with the whole idea of cancer screening and prevention of cancer, which obviously colonoscopy has been a vanguard in that space. But it's now in that same line of thought is taking a proactive stance in managing chronic diseases in the GI space, which we're not really attuned to. And alongside with that is also, taking the idea of improving quality, not just from, what you learn in your training and applying that and learning it from your practice management conference or your practice management courses you would go annually with the AGA or ACG, but it's applying quality improvement at a systemic level. Mm-hmm. This is something that obviously industries like Toyota and other companies like that, have really adapted well, to Six Sigma protocols and lean models and other methodologies like that. But how to take those methodologies and apply it in large scale groups like ours, so we can improve quality, performance, and outcomes across the board, not just based upon what you learn at the latest AGA conference or ACG conference. Mm-hmm.
And to add to that, the patient experience, it's very important from a compliance standpoint to track patient satisfaction very carefully. And as Nadeem said, be proactive if patients view their experience as not the best. So there are tools that we can use, as Nadeem said, to engage them early in chronic illness, but also to get some feedback from them as to what their experience has been, so that we can then improve on it.
Yeah, fantastic. I love the drift of how our, the directions that our conversation took. I want to thank both of you, Dr. Nadeem Baig and Dr. Bob Gialanella, for sharing your insights and being open to going with the flow of our conversation today. Were there any final thoughts that you would like to leave us with?
Well, again, Praveen, I want to thank you very much for allowing us the opportunity today to talk about our very exciting journey through Allied Digestive Health, and more importantly, our goals for quality, compassionate patient care. And this is a forum for all gastroenterologists across the country, not just platforms. I'm sure we can reach many, many more practitioners than we could have without you. So we really much appreciate it. I thank you.
Thank you.
Yeah, Praveen, the same for me. It's been a great opportunity for us to have a nice pleasant, warm conversation, to share ideas and thoughts, both of our experiences and what we think going forward, but also really learning from you, and I've been getting through that book Scope Forward, and I'm about, looking forward to finishing in the coming weeks.
Thank you so much. This has been a real pleasure, and thank you once again.
Our
Wonderful
pleasure.